So I'm going to talk to you today about targeting the DNA damage response in gynecological cancers, trying to move beyond sort of PARP inhibitors. And the talk outline, if I can get this to move forward. So we're going to give you a brief overview of the DNA damage response in cancer, talk about what the opportunities will be or are to target the DDR in gynecological cancers, kind of circle back to where we are with PARP inhibitors as single agents and what we've learned through developing these drugs, and then focus on not PARP, but the ATR CHEK1 WEE1 axis, and present some of the work that I've undertaken in the UK before starting here. And then move into sort of targeted chemotherapy as a thing, which I don't think many of us think about in terms of targeting the DDR. And then finally, just to touch back into PARP inhibitors and talk a bit about PARP inhibitor resistance. So this is a very sort of simplistic version of the DNA damage response, and it's really grouped into 5 pathways, 4 of which are shown here on the slide. So mismatch repair, we know, deals with replication errors or mismatches, and these are the genes that drive that pathway. And this is one thing that we test obviously routinely now in endometrial cancer in terms of protein expression by immunohistochemistry. Base excision repair or single strand break repair is the pathway in which we target PARP1 with PARP inhibitors, and that's the key pathway to deal with damaged bases or single strand DNA breaks. And then double strand DNA breaks, we have 2 pathways. One is homologous recombination repair, which is an error-free pathway. It can only occur in late S and G2 phase of the cell cycle, and the key genes and proteins involved in this pathway obviously are BRCA1 and BRCA2, which you'll have all heard of, and RAD51, not RAST51, that's a typo, and it's homologs. We have an alternative DNA double-strand break pathway, non-homologous end joining, that could occur at any phase in the cell cycle, and it's error-prone, and the key sort of proteins involved in that and genes are DNAPK and the Q7080 heterodimer, and part 1 also has a role to play. But we mustn't forget that cell cycle checkpoint control is also important in DNA damage response, because if we have DNA damage, we need to halt the cell cycle to enable the DNA damage to be repaired and not progress through replication. And so the DNA damage response and repair sort of pathways now we know incorporate ATM, ATR, and CHEK1 and WEE1, which would all be involved in cell cycle checkpoint control. So what aberrations in the DDR are common in gynecological cancer? So if we start off with ovarian cancer, and if we look at DDR alterations by subgroup, if we sort of focus on high-grade serous, which is the most common type of epithelial ovarian cancer, we know that it's very rich with abnormalities in the DDR. Almost all of them are mutant p53, which we know can lead to loss of the G1S checkpoint control to high levels of replication stress. BRCA1 and BRCA2 mutations occurring in about 20%, and then the wider sort of umbrella of homologous recombination deficiency occurring in up to 50% of all high-grade serous ovarian cancers. We do see mutations in single genes that I've listed here, but they're not common, but we do see them. And then there are other deficiencies that we can also target related to the DNA damage response. Looking at clear cell, we know that ARID1A mutations are common. P10, which is a regulator of RAD51, is also common. And in endometrioid, we also see ARID1A, P10 abnormalities, and we know we can see mismatch repair deficiencies. If we look at endometrial cancer, everybody knows this has been well developed and established as part of the group here, led by Jessica, in terms of the genomic subgroups in endometrial cancer and the PROMISE molecular classification. And we're doing mismatch repair deficiency testing and p53 mutation testing, hopefully as normal or standard in these cancers, or we should be, in poly mutation testing is hopefully coming. But we know that there is more than this in terms of abnormalities in endometrial cancer. And if we look at the DNA damage response and look at homologous recombination deficiency, so this is a small study which was published by a group led by David Church in Oxford, and it used a functional RAD51 immunofluorescence foci assay looking at unselected endometrial cancer cases, and 24% of them by this assay were HRD. And if you focus on the non-endometrioid, sort of the serous p53 mutant subgroup, then you get up to 46% of them being homologous recombination deficient. Other abnormalities are seen in endometrial cancer, such as mutations in ATM, BARD1, BRIT1, CHEK2, and RAD51. And again, P10, which is a regulator of RAD51, Somatic P10 mutations are common, particularly in the endometrioid DMMR subtype of endometrial cancer. ATM mutations are also seen, as I said, but not that common, but perhaps occurring in up to 15%, and particularly seem to be more common in carcinosarcomas than other subtypes. Cervical cancer, HPV-associated cervical cancer, by definition, should have deficiencies in the DNA damage response, and this could be applicable to all, HPV-associated cancers. And in gynae, we're talking about cervix, vagina, and vulval. So we know that HPV activates the DNA damage response to facilitate its viral replication through homologous recombination. And there have been several studies showing that HPV activates and manipulates both ATM and ATR to promote genome stability and ensure efficient, amplification of its genome through homologous recombination. So it has been shown that inhibition of ATR or CHEK1 can block this effective replication of HPV in infected genomes, suggesting that HPV-associated gynecological cancers could be, ripe for targeting with DDR inhibitors. Somatic mutations in ATM are also present, not hugely common, but reasonable numbers, up to 10 to 15% of cases. So, a quick whiz through that suggests that, in summary, there appear to be many opportunities to target the DNA damage response in gynecological cancers as single agents, which is what I'm going to be focusing on today, but also in combination to potentiate DNA damaging chemotherapy, radiotherapy, or other targeted therapies. So what DDR-specific inhibitors do we currently have, from early phase clinics in development? Well, we all know about PARP inhibitors, which are the most developed of the DNA damage response inhibitors. Some of these inhibitors now have names. They're so far developed, and obviously all of the PARP inhibitors listed there aren't all necessarily approved in ovarian cancer, but we know niraparib, olaparib, and rucaparib are. So I want to go and focus a little bit on PARP inhibitors, not to tell you what the data shows and to go over things that we already know, but maybe just to go through how they were developed and what biomarkers were developed to suggest response, and how we can perhaps learn lessons from this to take forward to target other DNA damage response targets. So this is the current approvals of PARP inhibitors across all cancers. So we see approvals in this is sort of global at FDA approval as opposed to accessible in Canada, but we know there's approvals in ovarian cancer in the frontline setting and in the recurrent setting, and now in combination with bevacizumab in the frontline setting through the Paula trial. There's also approvals in breast, pancreas, and prostate for various settings. And we know that the target originally for PARP inhibitors was mutant BRCA1 and BRCA2. So the original story seemed very simple, but then it has evolved into something a little bit more complex. And I think this is applicable to the development of DNA damage response inhibitors beyond PARP. So we know that the original data in cell lines, and these weren't even cancer cell lines, that showed that if you took out BRCA, you had exquisite sensitivity to these cell lines to rucaparib and olaparib. And this original work was done with forerunners of olaparib and rucaparib by the group in Newcastle and Sheffield with rucaparib, and the Institute for Cancer Research in London with olaparib. And then trials showed this, that if you gave olaparib to BRCA mutant cancers, you got a good response, much greater response than was expected, and this was a single agent. And then this was shown with other PARP inhibitors such as rucaparib, showing a response rate of almost 60% as a treatment on its own in BRCA mutated high-grade serous ovarian cancer. And this was obviously based on early preclinical data and early phase trial data, suggesting that this was the key biomarker. This is how we know that PARP inhibitors are going to work in ovarian cancer. And this still plays out today. So this is the updated 5-year survival for SOLO-1, which was a trial in the frontline setting, randomizing women to placebo or olaparib following completion of chemotherapy who had BRCA mutated high-grade serous ovarian cancer. And this is sort of stunning results showing olaparib 56 months versus 13.8 months in terms of median progression-free survival. And the top curve, which is the olaparib curve, continues to sort of flatten out, suggesting that there will be a survival benefit for these women. So we know that this is a key biomarker for PARP inhibitors, but I want to talk a bit about the evolution of how we sort of generated a bit more of a broader church approach to PARP inhibitors. So In terms of BRCA itself, is it tumor agnostic? So is it something that works in all cancers? Well, the truth is that it actually doesn't. So if you look at PARP inhibitor response across different cancer types, and if you look, say, at the prostate cancer data from the Triton studies or the pancreatic cancer data from the RUCA-PANC studies, we see that the response rate to single agent monotherapy PARP inhibitors, 44% and almost 16% for the pancreas study, is much lower than what we see with the high-grade serous BRCA ovarian cancers, where we had in Aerial 2, for example, 80% response rate in the BRCA group. Why do we see these differences? Well, there are a number of possible reasons. I think one of them is in ovarian cancer, we select patients out by platinum sensitivity, which in itself is a biomarker. So we're enriching our BRCA group for those that are platinum sensitive, and you don't get that necessarily in the other cancer types where platinum is not a key backbone for treatment. And the other reason might be because of the coexistence of the p53 mutation alongside the BRCA mutation, and maybe it's about the degree of homologous recombination deficiency rather than the mutation itself. And this is sort of further being discussed in a review that I contributed to that was published 2 years ago, looking at the drivers of response to PARP inhibitors. It may be more key that it's homologous recombination rather than the BRCA mutation itself. So we learned that it was BRCA, obviously, in terms of a driver, but did we know that somatic was as good as germline? And there are lots of studies now showing that this is the case. So in Aerial 2, we showed that somatic mutations responded just as well as germline mutations. And there are small numbers of patients that have contributed to the other studies, such as Study 19, NOVA, showing that somatic mutations do actually respond just as well as germline. So if we're looking to target other targets with DDR inhibitors, we shouldn't just be focusing on germline mutations. And there is a trial called the Azora trial, the results of which were awaited, which focused specifically on the sort of somatic BRCA and HRD, the other non-BRCA mutations, and that is awaited. We then started to move, obviously, beyond BRCA into homologous recombination repair because of this idea that it's not just BRCA driving homologous recombination deficiency. And I've just listed here, just as examples, other things that can cause this sort of BRCA-ness phenotype. And we realized that obviously we're looking for a wider biomarker called HRD, and how can you do this in cancers, and how challenging can this be? So if we look at, say, single gene mutations in the HR pathway, what have we learned from those and their response to PARP inhibitors? So Aerial 3 was a trial that looked at all comers, and it also obviously looked at their mutational status. And in that trial, we did see that RAD51C, RAD51D mutations were predictive of response to PARP inhibitors, and they're part of the HR pathway. The challenge is they're not common, so they represent about 3 to 5% of all high-grade serous ovarian cancers. If we look in breast, we know that PALB2 mutations confer, a predictive biomarker for PARP inhibitor sensitivity. This is not as common in, say, gynecological cancers as it is in breast, and all of the women with PALB2 mutations had high HRD scores, so maybe would have been picked up with just a generic HRD test rather than specifically looking at PALB2. We also know from the prostate studies, again, that ATM mutations confer could be used as a good predictive biomarker for PARP's inhibitor sensitivity, but again, are not that common in gynecological cancers. So again, HRD testing might be better. In terms of HRD testing, there are a number of genomic signatures and tests which are now established and are used as companion diagnostics with approvals in ovarian cancer. So we've got the Myriad MyChoice assay, which I'm not going to go into a lot of detail, but you end up through analysis of FFPE tissue, a score which can be greater or less than 42, and therefore you have HRD positivity. We've got the Foundation Medicine LOH HRD score, which is based on a cutoff of 16%, suggesting HRD positivity. And these, as I say, are used in companion diagnostics associated with the clinical trials that I've listed in brackets in ovarian cancer. There's another test called the HR Detect, which is a predictor of BRCA1 and BRCA2 deficiency based on a mutational signature 3 signature. This is thought to be maybe more sensitive than the Myriad MyChoice assay, but it's not currently approved to be used as a companion diagnostic in gynecological cancers. In terms of how good are these tests, as biomarkers of PARP inhibitor response? Well, I'm going to show you two sets of data here. So the one on the left is Aerial 3, which was essentially giving the PARP inhibitor rucaparib versus placebo in recurrent high-grade serous ovary. And then the trial on the right, which was similar, but the PARP inhibitor was niraparib versus placebo, again in the recurrent setting. So we can still see that the greatest difference in response was seen in the BRCA population, but also the test was able to differentiate patients that had homologous recombination deficiency and had a reasonable response and a difference between placebo. But if you look at the bottom here, you see the intention to treat population, which includes those that are non-BRCA, non-HRD, as determined by these two tests. And we still do see a difference. So we know that the current HRD testing will be missing some patients who in these studies were grouped in the non-HRD group, but did have a good response to PARP inhibitors. So these tests are not perfect. So what about functional biomarkers in terms of PARP inhibitor response? And this might, again, have implications for looking at targeting, say, ATR with ATR inhibitors. So we know that this pathway is complicated and obviously BRCA is key, but there are other things involved and you can look at lots of different mutational abnormalities, but is there a sort of way of assessing the pathway in terms of its function? And we had developed through my PhD at RAD51 functional foci assay, looking at a twofold increase in RAD51 foci in response to DNA damage. And we showed that you could do this as a functional test in primary cultures developed from patient societies. And we found that 64% of high-grade serous ovarian cancer samples had a HRD phenotype through this test. And that did fit actually with their subsequent response to PARP inhibitors. This approach has also been taken forward in breast cancer, and this is work looking at paired biopsies after 2 weeks of rucaparib. And when they looked at the RAD51 foci deficient groups, so the sort of not able to form RAD51 foci in response to the DNA damage, these patients were the ones that had BRCA mutations, PALB2 mutations, RAD51C methylation. So those tests could be done as individual tests, but this assay sort of did a collective functional test and showed that they were HR deficient. In terms of, is this practical? I mean, this has been questioned, and the assay that we developed is a difficult assay to do, and it requires real-time assessment and development of primary cultures, and patients need to be near research laboratories for this to happen. You can resurrect acidic fluid cell pellets and try to do this, retrospectively. In terms of this breast assay, this also hasn't been developed or incorporated into any clinical trial that I'm aware of. So there are practicality issues with this sort of functional biomarker assessment. Swinging right back to sort of platinum, I think that we always forget in ovarian cancer that we give platinum, and therefore we can use this as a sort of biomarker. And we know that platinum sensitivity is a pretty good surrogate biomarker for homologous recombination deficiency. It's obviously not exclusive, and it does correlate very well in all studies that have been done so far with response to PARP inhibitors. And this is an example of where it can be useful. So this is data from the Quadra trial looking at the use of niraparib in a sort of very heavily pre-treated population. And this was as a treatment in itself rather than a maintenance treatment. And if you look here, you can see that even in the HRD negative or unknown groups, you could see that platinum sensitivity, which is the pink here, correlated well with response, even where HRD testing couldn't help. So I think platinum sensitivity is a useful biomarker for PARP inhibitors, and maybe we can consider other chemotherapy sensitivities might also be useful to help us direct other DDR targeted agents. So in PARP inhibitors, I think we have learned that we started out with a very simple solution. We have a biomarker, it is BRCA, and that does remain probably still the best biomarker for response. But I think we've realized that you can broaden the net to this homologous recombination deficiency biomarker, but obviously current tests are imperfect and won't capture all patients. And I think we mustn't forget the use of chemotherapy in targeting the DNA damage response and giving us an indicator of cancers that might respond. So the reason that I wanted to show all that is because this is something that these lessons that we can learn and take forward in terms of targeting other DDR targets. So looking back to this original slide, I want to move on to looking at the CHEK1 ATR-We1 axis and see what's been done in this area, and just show you some of the work that we've done in Newcastle as part of the group that I used to work in. So CHEK1 inhibitors were the first in terms of inhibitors of this axis to be developed, and they were actually developed over 20 years ago. Unfortunately, they had lots of problems initially with poor PK and PD, and they had also problems with cumulative normal tissue toxicity, which was specifically cardiac toxicity. So it took a while for more specific, more potent CHEK1 inhibitors to be developed, and some of the pipelines of some of the companies, such as AstraZeneca, moved on obviously to ATR inhibitors and subsequently WEE1 inhibitors. But all of these agents sort of are inhibiting a similar axis in terms of cell cycle checkpoint control. Unlike the evolution of PARP inhibitors, despite, as I say, more than 20 years of sort of drug development pipelines of this axis, there aren't currently any approvals of these drugs or phase 3 clinical trials, as far as I'm aware of, yet. So if we focus on ATR and the DNA damage response, this figure might not project very well, so apologies because it's a bit small. But essentially what it's trying to show is that when you have DNA damage, ATR and obviously ATM are also activated, and ATR is critical to both DNA damage repair in terms of homologous recombination, and also it helps in stabilizing replication forks. It also will control the G2M checkpoint, and it does this by phosphorylation of CHEK1, which is shown here, and then CHEK1 subsequently activates CDK1 and 2 and WEE1. ATR is predominantly activated by replication stress, and this can happen as an accumulation as you get single-strand DNA breaks accumulating and then stalled replication forks, which happen as you give PARP inhibitors. In cancer cells, they might be more prone to targeting ATR because they are more reliant than normal cells on the G2M checkpoint, because they have lost P53, which obviously is useful in controlling G1S checkpoint control. And also cancer cells with homologous recombination deficiency might be more prone to targeting ATR. And this is something obviously that we can exploit with ATR inhibitors. So there are 6 ATR inhibitors in the clinic in early phase clinical trials. The ones in blue I've just put there are ones that I've worked on either preclinically or in early phase before coming here. The hypothesis for ATR monotherapy, just to put it really simply, is that if you give an ATR inhibitor in the presence of a cancer cell that has DNA damage response deficiencies, then obviously you will get sensitivity. And one of the most common ways that you can get this sort of Achilles heel for sensitivity is through ATM mutations. So ATR inhibitor monotherapy, we've done some early phase clinical trials. As I say, I've been involved in the 2 trials that I'm going to present. And what did we learn from them? So ATM loss, this is a study looking at specifically at cancers with ATM loss, and it was the VX970 Vertex ATR inhibitor, which has now become a Merck product, and it's an intravenous ATR inhibitor, unlike the AstraZeneca version, which is oral. So this is a patient from this study who had ATM loss by immunohistochemistry and colorectal cancer, and they had a complete response which was durable up to 29 months. This is just CT scans of the target lesions showing the complete response post 29 months of treatment. And this cancer, when they analysed it further, had other DDR deficiencies. So it had ARID1A loss, again by IHC, and it was thought that this cancer was very reliant on ATR, and therefore it's not surprising responded to an ATR inhibitor. Now, what was really interesting about this patient in the study, because the dose escalation continued, this patient was in one of the early cohorts, and this patient was exposed to a very low dose of the ATR inhibitor, 60 milligrams per meter squared weekly dosing. And it's suggesting that if you have, high levels of replicative stress because of this sort of genomic background in the cancer, then maybe you only need very low doses of an ATR inhibitor, which obviously goes against how we develop these drugs, because we develop them up to maximum tolerated doses. So maybe higher doses aren't necessary, and therefore less toxicity could be expected. And that's just something that I'm going to talk about in further slides. The other study that I was involved in was the Bayer ATR inhibitor, which is an oral inhibitor, and it was initially liquid actually, and then developed into tablet capsule formulation. And it's given intermittently 3 days on, 4 days off. And this is just some data from patients that took part in this trial. And you can see on the waterfall plot here that the ones that had the good response were obviously those that had loss or mutant ATM, and those responses were in different cancer types, and they were very durable. 21 patients, as I say, were analysed, and 11 of those had ATM loss or mutations, and the loss was just done by IHC, and 4 of those had partial responses, 3 had stable disease. Now, interestingly, BRCA mutation in the study, although it's small numbers, was not associated with response, and obviously not all patients with aberrant ATM responded, so there's still, you know, more to tease out about this. It's not as simple as our BRCA and PARP in ovarian cancer story. These studies are ongoing, and a lot of the ATR inhibitor studies are looking now in combination, such as with other DDR inhibitors and also with immune checkpoint inhibitors. And I'm not going to show those or talk about that. So, as I said, it looks like ATM is a good biomarker for targeting the ATR CHEK1/WEE1 axis, but it's not that simple in gynecological cancer patients. And that's mainly because ATM mutations, germline mutations, are not common, and somatic mutations are also not common. And this data here shows the sort of percentage of cases across cancer types with ATM mutations. And the ones with the stars here, this is endometrial cancer, this is specifically cervical cancer, and then this one here is, sorry, I can't read my own slides, carcinosarcoma, yep, and then we've got here ovarian cancer right down the bottom here. So it's not a high sort of, we're not seeing these mutations if we tested patients for them at high incidence. So do we need a more broader predictive biomarker of response to these sort of agents in gynecological cancers, such as moving from BRCA to HRD as we did in PARP inhibitors? And I think the way to probably do this is by looking at something called replication stress, so high levels of replicative stress, which are seen in cancer types and possibly are seen more commonly in ovarian cancer and other gynecological cancers. So this can occur, replicative stress can occur as a result of different pathways abnormalities, such as if you have mutant p53 and you lose the G1S checkpoint control, such as if you see cyclin E1 amplification, which we know we see in high-grade serous ovarian cancer, that can lead to premature G1S phase entry and replication stress, and also things like MYC oncogene amplification, among others, can cause replicative stress. So I want to focus on some of the areas that we've looked at in the lab in Newcastle and in the clinic, as I say, using both cell lines and preclinical models looking at this. So this is one of my PhD students' work. Oh, I'll go back. Alice Bradbury. So she completed a 4-year PhD earlier this year, which was funded by the MRC in the UK and in collaboration with Merck, trying to look at single agent sensitivity to VE821, which is a precursor to VE970 in ovarian cancer, and particularly focusing on high-grade serous ovarian cancer. The hypothesis surrounding this is obviously that ovarian cancer is sort of ripe for high levels of replicative stress. And we know that almost 100% of them have mutant p53. As I say, 50% of them are HRD, 20% are thought to have cyclin E1 amplification or RB1 loss. And then if we look away from the high-grade serous to clear cell, we know that ARID1A mutations are common, as I said earlier, and also 10% of them may have NF1 loss or mutation. So there's lots of possible targets to consider that high-grade serous and clear cell have high levels of replicative stress that could be targeted with ATR inhibition. So in Alice's PhD, we wanted to determine single agent sensitivity across ovarian cancers, and we wanted to look at single event determinants of sensitivity, such as mutations in BRCA genes or ATM or ARID1A. And we also wanted to look a little bit like we did with ovarian cancer with PARP inhibitors, at whether functional pathway assessment aberrations could be used as determinants of sensitivity, such as HRD or a functional replicative stress biomarker. Other work also included the understanding between the relationship of DNA PK and ATR, which I'm not going to show here. And also we wanted to look at whether there was a difference between high-grade serous and non-high-grade serous histologies in ATR inhibition. And most of the work that Alice undertook was in human ovarian cancer cell lines, which obviously can be a limited thing to do in terms of patient models. But we also looked at patient-derived primary cultures from malignant ascites. And this work was in collaboration with Merck. So we used the Merck portfolio of ATR inhibitors, which includes VX970, which was the Vertex inhibitor that was taken over by Merck. So this is the cell line panel that she used, and I don't want to talk you through all of these, but obviously it's just to show you there was a mixture of high-grade serous and non-high-grade serous cell lines, and these are the common ovarian cancer cell line panels that are used. I was going to show you some unpublished work today, but I haven't received approvals from Merck to do that. So I'm just going to show some limited published and presented data, including work that Alice presented at AACR last year. So what we found with VE821 is that ovarian cancer cell lines display a very broad spectrum of sensitivity to ATR inhibition. And this was shown if you group by high-grade serous and non-high-grade serous. We found that the high-grade serous cell lines were statistically more sensitive than the non-high-grade serous cell lines. We also found that the inhibition was not dependent on cell doubling time. So you might expect cells that have a higher doubling time to, a shorter doubling time to be more sensitive. And it also wasn't dependent on the degree of ATR inhibition, which was fairly inhibited across all of the cell lines at the doses that we used. In terms of biomarkers of response, we looked at expression of the common genes and proteins that we talked about that might indicate a response, looking at protein expression by Western blot and mRNA expression by Illumina next generation sequencing. I'm not going to show you all of the data, but interestingly, what we found was that the only things that came out of interest were reduced RAD51 expression and increased cyclin E1 protein expression conferred sensitivity to VE821, which you might expect. Oddly, high ARID1A protein expression conferred sensitivity, not low, which would go against the other published literature. But we also found that loss of ATM did not confer sensitivity, and again, this is in cell lines, to VE821. Protein expression results by Western blot correlated much better than the mRNA results, and maybe that's more representative of functional loss at the sort of protein level. In terms of BRCA, because this is obviously an area of interest, we think that BRCA patients might respond better because of HRD to ATR inhibitors. And we showed that if you look at isogenic matched cell lines, so this is the UWB1289 plus or minus BRCA1 cell line. If you look here, you can see a difference with the BRCA null cell line much more sensitive than the BRCA one cell line. However, this is also a BRCA1 mutant cell line, and there wasn't any difference. So the only difference in BRCA1 mutation sensitivity was seen in the isogenic matched cell lines rather than other cell lines. In terms of the primary cultures, and this work is ongoing, and this is stuff that I can't present today, but we did show that the more rapidly dividing cells were actually the least sensitive to VE821. And again, that's odd and is being explored further in the work that's ongoing. I mean, the data that Alice has generated, and some of it, as I say, I've not been able to show you today, but it is interesting because it's highlighting the difficulty in predicting sensitivity to ATR inhibitors. And it is more complex, perhaps, than it is to predict sensitivity to PARP inhibitors. In terms of mutations and aberrations, I think there's probably a hierarchy of aberrations that determine ultimate sensitivity. Now, we did show in some of the functional work that I can't show you the data for, but that probably loss of HRD and dMMR confers sensitivity to ATR inhibitors as well. Also, oxidative stress in terms of replication stress, also potential predictive biomarkers. And I think the challenge is, how do we actually assess this or measure this in ovarian cancer? This kind of idea has also been taken forward in clinical trials. And this is an early study of a CHEK1 inhibitor that we led in Newcastle. So not an ATR inhibitor, but a CHEK1 inhibitor, but a similar principle. And it was using SRA737. And SRA737 is an oral, highly selective CHEK1 kinase inhibitor. And it was developed actually in London through the Institute for Cancer Research and through CI UK. But then ultimately the drug was taken forward by Sierra Oncology, who are actually a Canadian-based biotech. So the trial of SRA737 was initially to look at monotherapy and find a dose that was safe and a schedule that was safe. And once that was established, expansion cohorts were undertaken with the idea of prospectively selecting patients who may have genetically defined replicative stress high cancers to assess efficacy of CHEK1 inhibitor monotherapy. And this is basically what we did. So we looked at ovary, prostate, non-small cell lung cancer, squamous cell carcinomas, which included anal cancers and head and neck patients, and colorectal. And they had to have sort of in their Foundation Medicine 1 archival tumor assay, they had to have markers of replicative stress. So things I've already talked about, such as MYC amplification or cyclin E1 amplification, P53 mutation for high-grade serous, and obviously BRCA were also enriched in this patient population. So the results of the study have been presented at ASCO, but not published yet. So there was 107 subjects treated across the escalation and expansion cohorts. And the largest expansion cohort was actually high-grade serous ovarian cancer, and the second largest was colorectal cancer. And I put lots of patients into this study. So this is the high-grade serous ovarian cancer patient data, and we found that of all the tumor types, high-grade serous was the most sensitive to CHEK1 inhibitor monotherapy. These were very heavily pretreated patients, so I think the average was 5 prior lines, but there was a reasonable disease control rate reported at 54%. Now, if we look at response to monotherapy across all of the tumor types for the best responding patients, we can see that there are 3 sort of pathway abnormalities that are coming out as potentially, biomarkers of response, and they are the Fanconi anemia BRCA pathway, cyclin E1 amplification, and abnormalities in PI3 kinase pathway. So these data do suggest that, there's probably more than one test that is required to identify patients for CHEK1 inhibitor monotherapy. And it also suggests that maybe in those patients that didn't respond so well, maybe you need to improve sensitivity by adding additional extrinsic replicative stress, which you could potentially do with low-dose chemotherapy. And so this study is also involved a gemcitabine, low-dose gemcitabine arm, which I'm not presenting today, and that data has also shown reasonable levels of efficacy across the tumor types. I'm going to show you this now because this was only published actually this month, but this is kind of on a similar theme. So this is data that was presented at ASCO about, I think it was last year, looking at ATR inhibitor monotherapy, ATR inhibitor therapy with gemcitabine versus gemcitabine alone in high-grade serous, heavily pretreated ovarian cancer. And this is the translational analysis of this study, which was, as I say, was published this month. And what they did for all the patients' tumors in this study was they looked at replicative stress in archival FFPE tumors, and they defined high replicative stress in patients that had any one of these markers that you can see here in the summary, such as, again, cyclin E1 amplification or MYC amplification and so on. When they looked at the response to gemcitabine on its own, and then the response to gemcitabine bisotertib, which is actually AstraZeneca's ATR inhibitor, they actually showed, and it's very small patient numbers, but it's just, hypothesis sort of generating and interesting, that the patients that had high replicative stress did very well with gemcitabine versus those that had low replicative stress. And the addition of the ATR inhibitor with the gemcitabine, didn't seem to add anything. So what they were suggesting here is that the higher the replicative stress that you have, it might be that you don't need anything else other than low, gemcitabine, which obviously would exploit that. And patients with lower replicative stress might need a combination to help. Now, what would be interesting in this study is if they'd also had an ATR inhibitor single agent arm and looking at levels of replicative stress versus high and low to see whether the response was similar to, say, the gemcitabine on its own. So it does suggest that we can target our chemotherapy better in high-grade serous ovarian cancer if we understand the DNA damage response better in terms of replicative stress markers. And this is the next thing that I want to talk about. So we've talked about DDR inhibitors, PARP inhibitors, CHEK1, ATR, and obviously WEE1 is part of that axis. But what about chemotherapy selection? So can we target the DNA damage response in gynecological cancers just with our chemotherapy by better selection? And so this is some data that we have been generating over the last 2 years in Newcastle as part of a bigger preclinical project. But this is just data in cell lines and primary patient derived cultures, looking at chemotherapy response to the sort of common gynecological sort of ovarian cancer chemos that we give: carboplatin, paclitaxel, doxorubicin, and gemcitabine and topotecan in high-grade serous ovarian cancer and non-high-grade serous ovarian cancers. And we also compared the chemotherapy response to a PARP inhibitor. In this case, we used rucaparib, and we also looked at an ATR inhibitor, and this is not shown as part of this publication. So we wanted to correlate any genomics or transcriptive functional aberrations seen in the DDR with chemotherapy response to see whether or not we could actually target our patients better by selecting different chemotherapies. Now, the results are interesting, and what they showed was, this is the data for all the chemotherapies, and the rucaparib is here. All the cell lines had a varying sensitivity to each chemotherapy, and the greatest range in sensitivity was seen in carboplatin, which is the most common drug that we use in ovarian cancer, with a 31-fold variation from the least to the most sensitive. There was a clear correlation between the sensitivity of carboplatin and rucaparib shown here, which is completely as expected and understandable. But interestingly, in the high-grade serous versus non-high-grade serous cell lines, we saw that paclitaxel sensitivity was much greater in the non-high-grade serous group. It wasn't statistically significant, but it was an observed finding. In terms of HRD, so we looked at all of these cell lines and we categorized them by this functional RAD51 flow cyte assay as HRD or HRC, HR competent. And we saw that there was obviously, and as expected, significantly more sensitive to carboplatin and rucaparib in the presence of homologous recombination deficiency. But interestingly, no difference in the sensitivity of the other chemotherapies, regardless of HRD or HRC status. In the patient's primary cultures, we also saw a similar pattern of rucaparib and carboplatin sensitivity aligning, but we also saw with the HRD patient data that there was an association with doxorubicin response. And sometimes I know that I do select doxorubicin over Taxol for patients who are known to be HRD or BRCA, because that would fit with previous published data. Other functional assessments of the pathways showed that non-homologous end-joining activity correlated negatively with carboplatin and rucaparib response. And we also saw that the MMR defective cell lines were more sensitive over the other chemotherapies to carboplatin, rucaparib, and topotecan. Now, this is interesting because we might expect these cells to be platinum resistant and PARP resistant, but we do know there's an association with MMR deficiency with MRE11 loss, which could obviously result in HR deficiency. Also, and in keeping with the data that I was just referring to regarding the study with gemcitabine and ATR inhibitor, we saw that higher levels of replicative stress or oxidative stress were associated with increased sensitivity to gemcitabine. So these studies do suggest that if we are able to target a chemotherapy, maybe we can make different choices for our patients rather than a one-size-fits-all approach. And this obviously means we need to analyze cancers in more detail. And this obviously isn't always possible outside of clinical trials or routine clinical practice. Now, this work with Shweta is continuing, and we're examining patient samples now pre and post chemotherapy to again look for functional differences in the DDR and how they might correlate with response to chemotherapy, and that data is awaited. So finally, just in the next 10 minutes, I just wanted to touch on PARP inhibitor resistance. So we know that PARP inhibitors are the most developed in terms of the DDR targeting inhibitors, and they have shown incredible, improvements in the lives of patients, particularly women with BRCA and HRD associated ovarian cancer. But as with all great treatments, we know that resistance occurs, and it can either occur primarily, so patients don't really ever respond, or they have a very short response. And it can also occur in patients who've had a very good response and be acquired over time. And as I say, both of these mechanisms are possible. If we want to understand resistance, then we obviously need to know why patients responded in the first place. And we know that there are obvious mechanisms that have been reported for BRCA patients, but less well defined for the non-BRCA population. In terms of what we do know, we've obviously known this for a while, that if you give platinum or a PARP inhibitor, you can induce resistance to secondary BRCA mutations, which obviously restore homologous recombination function. And this was first discovered, many years ago, over 10 years ago, and published. Is this an issue in real life, and is it clinically relevant? Well, the answer is yes. So this is the data I'm going to show you from the Ariel 2 study, which was rucaparib in women with high-grade serous ovarian cancer. But this is also reported in other cancer types, such as breast, prostate, and pancreas. So in Ariel 2, they looked at patients who were obviously all post-platinum, and this is even before treatment with the PARP inhibitor. And in patients who had secondary reversions, 18% of those were patients with platinum refractory disease, and they had a poor median progression-free survival. And there was also seen in patients with platinum-resistant disease, and again associated with a less great median progression-free survival. You can't see this because it's at the bottom of the trial, but bottom of the slide. But post-treatment with rucaparib, there were also reversion mutations picked up. So these were seen pre-treatment and post-treatment as a response to treatment pressure. So other mechanisms of resistance are known and documented, and we've talked about the BRCA-related ones, but there are also ones related to what's called DNA damage response rewiring, particularly where you have restoration of protection of replication fork, and ATR would be important there, and you have restoration of competent homologous combination, so that that initial Achilles heel in the cancer is lost. And this is where ATR inhibitors could potentially come into play, and there are trials ongoing looking at ATR inhibitors to potentially overcome PARP inhibitor resistance. There are obviously other mechanisms of resistance which we've not talked about, such as just drug efflux mechanisms, where the drug's just being pumped out and therefore not being retained in the cell. And there are other things related to PARP itself, such as PARP mutations or PARP loss. So some of these resistant mechanisms are well described, and some of them are less understood. And I wanted to just talk briefly at the end about a proposal that I'm trying to develop here, which is some new work looking at PARP inhibitor resistance. And we want to look at it in the first line setting, which is where PARP inhibitors have now gone in ovarian cancer. So the reality in terms of the standard of care at the moment is women get a PARP inhibitor following response to chemotherapy and are following surgery, and they can either have olaparib if they're BRCA mutant as per SOLO 1, or they get niraparib for up to 36 months as per the PRIMA trial. Now, we know at the moment we don't have HRD testing funded in British Columbia, so we're selecting patients for PARP inhibitor therapy going right back to the beginning using BRCA or non-BRCA. So we don't know who's HRD and who's HRP. And the reality is that we're often looking at platinum response to help us decide that, but we don't have a HRD test to rely on. And if we look at all comers to the PRIMA study, so that includes the HRD and the HR proficient or competent group, then obviously the benefit is fairly, reasonable, and that's why it's been approved for all comers. But if we look specifically at the HRP group from the trial, then the benefit to having niraparib is only 8.1 months with niraparib versus 5.4 months without. So this is a small benefit. And what I'm interested in looking at is those patients that do not respond that well, so perhaps progress within the first 12 months of a PARP inhibitor in the frontline setting. And I think the key questions are in this group, is this primary resistance? So did they not have underlying HR deficiency, or have they acquired resistance, and what's the mechanism? What treatment to offer these women next is actually very challenging, because they may not respond to subsequent platinum. We don't have information really about what's the best chemotherapy to use, and should we be trying to get them into another trial or a targeted agent. And the other thing is, this is becoming an unmet need population, because those patients that don't do well on PARP inhibitors in the first line setting will have a much poorer prognosis. And so we need to develop novel therapies in this area. So this is the sort of research questions and plan for this proposal. And we're going to be hopefully looking at what percentage of women do progress in the real world setting within 12 months, and what's the impact on these women on that treatment in terms of their sort of burden of tests and side effects, because this is important, and that this may need to include quality of life data collection as well. What's the physician choice of next treatment? We want to collect that, because that's going to be important to know, and what would be the response to that treatment. And then also to look at any relationship in the absence of a HRD test of PARP inhibitor response, such as clinical markers and CRS scores. There is some translational work that I'm proposing as part of this, and this is sort of the key aspect of the project. And this is to try to specifically develop from fresh biopsies of these patients, sort of primary PARP inhibitor resistance PDX models, to then look at doing further drug development combination testing, such as looking at other targeted combinations. And there are discussions ongoing with pharma about that. And the other thing that we want to do is characterize these cancers more in terms of what is the underlying deficiency that may be resulted in the original response, and what markers might be suggestive of resistance that could then be targeted, such as maybe have we got high levels of replicative stress or CNE1 amplification, which might suggest ATR inhibitors or targeting that pathway might be the right thing to do. So in terms of this project, the idea would be to have a laboratory project ongoing, and then we would hope to utilize existing members of the team, such as Faria Kabir, who's working with David and I now in ovarian cancer as part of the group, and also to utilize our hopefully newly appointed funded fellow, which is funded by GSK, to work on this project. So just to summarize, the PARP inhibitor lessons learned, I think, and the reasons that I showed those slides was just to sort of remind us that, we started out very simply that it was BRCA, and then we moved into HRD. And again, these signatures are not perfect, but they are all we have at the moment. But maybe we need to still look and strive to develop more functional assays. And we can go back to good old-fashioned chemotherapy to help us and guide us, such as platinum sensitivity, and that should not be forgotten as a useful biomarker. In terms of the beyond PARP inhibitor, lessons, I think we know that the ATR CHK1/WEE1 axis is the most investigated to date, but it is more complicated than the BRCA PARP story, unlike, unfortunately, what we first thought. And obviously, ATM loss and mutation seems like a reasonable biomarker, but not everybody responds, and this does have limited applications in gynecological cancers. And perhaps we need a more generic biomarker of replicative stress, and how would we incorporate the practicalities of something like that into practice. There are lots of studies ongoing, and some of those are in combination rather than monotherapy. And as I say, and I've already said this a couple of times now, good old-fashioned chemotherapy, can still be a targeted treatment. And perhaps we need to think more cleverly about how we offer women chemotherapy. And then finally, obviously, the next challenge is, of course, PARP resistance. And I think that targeting the DDR is going to be key in terms of potentially overcoming that. So just to acknowledge people, patients and families obviously took part in the studies that I've presented, and just to show you the team that I've previously worked with in Newcastle. Those of you that know Nicola Curtin will know that she's a character. This is her in one of her famous lab Christmas jumpers. And obviously Alice and Shweta, who did a lot of the work, and Shweta, who's continuing to do some of this work. And then thank you for listening, and I'm happy to take any questions.